Thank you very much for having me here. So I'm Chen. I do a brief introduction about myself. I'm currently a PhD student in economics at the Higher University, and I'm in my 5th year. So today, the study I'm going to present here is, well, the effects of dental hygiene, scope of practice, and autonomy on access to dental care. So this is a work co-authored with my advisor, Professor Mayhofer at Lehigh, and also Professor Timmons from San Francisco University and CSOR. So this is actually an empirical study, and as you see, we focus on a dental hygienist in particular. So my talk today is going to follow a typical framework of an empirical study, and I'll begin with a brief introduction of the topic and then give some background information, well, essentially about the policy change in the dental hygienist practice. And then I'll describe my data source and also the setup of my empirical model, and then I'll show the results and give a discussion conclusion. Okay. And also, so feel free to interrupt me if you have any question. Yeah, I think I don't need to spend too much time on that, on the what scope of practice laws is. But essentially, well, scope of practice laws is an important component of occupational regulations on healthcare providers. And scope of practice laws are regulated by state government, and it essentially specify what health providers can do and cannot do. And scope of practice really differ across different healthcare providers. So as Sarah mentioned actually yesterday, so scope of practice laws are especially important for advanced registered nurse practitioners, right? Because these professionals are generally required to work under the supervision with higher educated providers. So like in here, like dentists and dental hygienists are required to work usually are required to work under the supervision of dentists. So here, the change in autonomy level for dental hygienists is important as it affects the boundaries that between the two professions and what tasks and dental hygienists can render. So again, in this study, we're going to focus on the autonomy level, and here we identify 4 levels of autonomy, ranging from unsupervised to direct supervision. So basically, unsupervised is the highest autonomy for dental hygienist, with the direct supervision required is the lowest autonomy level for dental hygienist. So I'll discuss more about that later. So over time, we do see more and more states have essentially expand scope of practice to dental hygienists. So advocates for these laws believe that expanding SOP is one way to help dental providers meet the rising demand, maybe due to the ACA. And also, policymakers believe that these kind of laws will improve the efficiency in delivering the dental care, especially to underserved areas. But previous literature on scope of practice tend to focus more on labor market outcomes. The general findings are consistent with the theoretical prediction. Like more stringent regulations may reduce wages and employment for the regulated professional. So for dental hygienists in particular, 2 studies also have the similar findings, and they find that more stringent regulations on dental hygienists does reduce wages and employment of dental hygienists.
So in terms of expanding the scope of practice, were the 2 points, the efficiency point and then also the quantity of care, were they articulated by the legislature as the reason for expanding the scope of practice?
Now it comes to probably the policy endogeneity thing, right?
No, it's not so much endogeneity. I think as economists, we can make arguments as to why the scope of practice could be expanded. I'm just wondering if these were the reasons that the policymakers, when they introduced the legislation, that they made, right?
Okay.
Yes, it doesn't have anything to do with the econometrics. I'm just trying to understand, like, how do policymakers justify expanding scope of practice? Do they use the same efficiency arguments that economists use, or do they use other arguments?
I think so.
Okay. Okay.
Okay. So, well, there are fewer studies that look into healthcare markets. But again, as predicted by economic theory, more stringent regulations on the occupation tend to raise the price and reduce the demand for the healthcare products provided by the regulated healthcare provider. So there are two studies will look at nurse practitioners, and one is by Heiner et al. In 2016, and I think they use the claims data, and they do find that when there is more rigid regulations on nurse practitioner, there is an increase in the price of wild child visit, which was the task that nurse practitioners can practice. And the other study also look at the nurse practitioner independence, and I think it focuses on prescription authority in particular. And actually, this is also a study that is closely related to ours, and they also look at dental care utilization. So also, they find that the nurse practitioner independence does increase the frequency of routine checkups, and also at the same time, it decreases emergency room use. But the studies on dental hygienists want to focus on the healthcare product market, and two studies that show that stricter scope of practice for dental hygienists also raises the price of dental care services, especially for those preventive care. So in our study, we are trying to answer the question that whether expanding dental hygienist scope of practice improve dental care utilization. So again, we are trying to build up an empirical we're trying to have an empirical study on and try to analyze for the causal effect of the scope of practice for dental hygienists on dental care utilization. So,
now,
yeah.
in your model, are you going to look at the incentives for dental hygienists and dentists? For example, dental hygienists have a greater incentive to use sealants, where dentists have dentists have greater incentives not to do that, to use cavities or to fill cavities. Therefore, they can get more money down the line, where the incentives for hygienists are to deal with the issue at the point of service and don't have incentives to make more money later on.
Yeah, actually, I think I will talk about that later. But generally, in our data, we actually, it's more on the market side. So we do not have the information from like the provider side. So we do not see like the intention from the providers in particular, but we do find something in the market response. So we hope there could be some relationship with.
Yeah, you might want to look at incentives for both services.
Yep.
Where the dentist might have incentives to make more money down the line.
Right.
During subsequent periods where hygienists would have greater incentives to do things at the point, do less evasive services at
Right.
period T,
Right.
where dentists would have greater incentives so that they could make more money in T+1 and T+2.
Okay.
Do you have information on sealants?
Oh, sorry.
Do you have information on sealants?
I do.
Okay, there you go. I mean, yeah. People can interpret their own way, but I agree totally with Morris's interpretation. Yeah, and we just want to see what happens.
Okay. Yep. Yeah, I think we might want to hold the sort and later when I talk about the specific task, and we can talk more about that. Okay. All right. So here I want to provide some more information on the legislative status of the dental hygiene practice. So one good source for a good review of the dental hygiene practice environment is Dental Hygiene Professional Practice Index, which was first developed by Center for Health Workforce Studies in the year 2001. It actually, the index contains a large group of variables. Mainly, there are 4 components from legal and regulatory environment, which is just a focus on the licensure requirement for dental hygienist. And the second component is the supervision levels, and which is what we are going to focus on in this study. And then the third part is the task permitted. So it does assess that whether or not dental hygienists are allowed to perform like prophylaxis, sealants, x-rays within the state. And the fourth one, I think, is more related to financial incentive because it specifies whether or not direct reimbursement is allowed from either Medicaid or private insurance. Actually, the index is only there for 2001, and they later updated it for the year 2014. So for the time period in between, what we do is we are trying to track the changes. So basically, we look into the state's regulations related to dental hygienists, and we are trying to identify the policy changes in all the variables used in Dental Hygiene Professional Practice Index. So again, as I said, in this study, we are not gonna use the summation of the DHPPI, but rather we will focus on the supervision levels. And in DHPPI, they specify supervision levels in different facilities. So basically, it could be the private dental office, but also dental hygiene could practice like in schools or in correctional facilities. So there could be different levels of supervision levels in different settings, but here we really want to identify a clear policy change. So we will want to exploit the variation in the general supervision levels across all different facilities. Okay. So again, for the supervision levels, there are 4 of it. And from the lowest level, level 1, is the director's supervision levels. So essentially, under this supervision level, the dentist has to be present when the dental hygienist is practiced the service. And then it comes to the general supervision level. It's just dentist needs to authorize prior to the services, but need not to be present. And collaborative practice on a higher autonomy level, and basically it just need dental hygiene make practice without supervision and just need a collaborative agreement.
Do you have information on if hygienists can open their own offices? So for example,
yeah.
in Colorado, in Colorado, for example, thank you, they can open their own offices and operate independently.
Yeah.
Is that information available, and that might have an influence on both prices and wages?
Yeah, actually, it's also one variable in the DHPPI, and we also keep track of the change in that. But here, because we really want to focus on autonomy level, so we really include this as a control in our model, but not.
So do you have information on they can open up their own businesses?
Yes, it's called like whether or not dental hygienist is allowed to work independently in the state.
Well, independently and opening their own offices are different.
Yeah.
So you might want to check
Okay.
Statutes about where there are certain states where hygienists can have their own operations and independent of dentists. So it's an independent dental hygienist office.
Yes. Okay. So here's the map that shows the dental hygienist autonomy level in 2001. As we see in 2001, still there are almost 40 states that's still at level 1 or level 2, which is we consider a lower levels of autonomy, and only 7 states have highest autonomy level in 2001. And when it comes to 2014, only 1 state remains at level 1, but still there are about 24 states that's still at level 2, which is still considered low in terms of autonomy level. And for states with highest autonomy level, there's still only like 12 of them. Yes.
Do you have information on whether states went up or down the levels of autonomy, like becoming more restrictive or just more permissive?
So I have to, yeah, that's also one important thing. So actually, over time, we do see that there's only expansion in scope of practice. So that none of the states ever reduced the scope of practice for dental hygienists. Yes. So yeah, again, that was the policy change in, well, autonomy level that we're going to focus on. So here comes the data. So the outcome we're going to measure is the dental care utilization. And the data we use is the medical expenditure panel survey by ARC and HHS. And we use the years from 2001 to 2014. So MAPS is actually a nationally representative survey data. It contains information at the individual level. So it has a detailed, especially it has a very detailed information on dental care and also healthcare visits and also costs. And also it has a large number of social economic characteristics at the individual level. Since the information on the dental care visits, in addition to calculate on the total dental visits for each individual each year, we are also able to identify what services an individual has received during each visit. And so based on that, we further categorize those visits into preventive care visits versus dental treatment visits. And also, it has information on what providers are seen during the visit. So we are also able to identify whether it's a visit to dentist or it is a visit to dental hygienist, or it could be both. And for the cost, also it has very detailed information on that, and also for in addition to the total cost for each individual each year, we also break down into out-of-pocket payment or self-payment versus third-party payment. So also as a control, we include in our model the dental supply, and this data is available from BLS, and we use the dental supply on like dental hygienist, dentist, and dental assistant at state level. Because I think for the dental hygienist, in the employment data is only available at the state level.
Could I ask a question?
Yep.
So how many people write down that they've seen a dental hygienist and that's it in a visit? I mean, it's sort of amazing that that would even be a record, so.
Well, actually, it's quite low.
Yeah, so yeah.
Yes, I think it's somewhere, maybe 20%.
Was that high?
Yes,
That's very high. I mean,
really.
that's pretty amazing.
10
Okay,
to 20, yeah. I don't know.
cool. Very cool.
Yeah, so basically we are using a very basic difference in difference model. So the main outcome, as I said, is the dental care utilization. So we focus on visits and also costs. And the treatment variable we're gonna use in the study is the variation in autonomy level across states over time. And also we have a rich control of individual at the individual level from like the age.
Do you have any information on prices of the visit and/or quality of the visit? That is, measures of the overall quality of dental health.
Yeah,
So, for example, the issue of untreated cavities, which was mentioned earlier today.
yes, we really want to have information on dental care quality, but unfortunately, there isn't information there in our data set to, analyze for the dental care quality. Yeah, we will really want to see if there is some thing out there that we can use. So, yeah. So, and again, we also control for county level factors like education, population education, and also like county level, the income. Also, as a typical setup of a difference model, we also include the state and year fixed effects, as well as state-specific linear trends. We include in our study a robustness check that has models that without state-specific linear trend. So as a robustness check. Okay. So a little more about the setup of the difference in difference. So again, the treatment variable we're gonna use is the variation in the autonomy level, and we will really want to focus on the changes from lower levels, where we consider level 1 and level 2, to higher levels, which contain level 3 and level 4. So essentially, the control group, we are going to focus on the states that says dental hygienists in autonomy level remained 1 or remained 2, because really that is the largest group among the states. And of course, the treated group will be those who ever experienced the change. So again, the reason that we want to focus on the change from lower levels to higher levels is because still majority of the changes are coming from those states. So as we see here, states remain 2 is the largest group. And so we really want to use that as a control group. And also if we look at changes, well, from lower levels to higher levels, which means it's 1 to 3, 1 to 4, 2 to 3, 2 to 4. So that's what we really want to focus on. So in our results, we will present 3 panels. For the first panel, we are going to include, well, for the treated group, it's going to be these 4 from 1, 3, 1, 4, 2, 3, 2, 4. And control group are those remain 1, remain 2, remain at lower levels. And also, we really want to focus on the change from 2 to 3, because again, that's the largest group. And so for panel B, we focus on the change from level 2 to higher levels, level 3 and 4. And we further break down to a third panel where we have control group that is still those who states remain 2, but the treatment group is the states from 2 to 3. Okay, so here are the results. For the estimates from the difference in difference effect. So for the dental care visits, we focus on total visits, preventive care visits, and treatment visits. And for each of the variable, we also do something like 2-part model. So if we look at column 1 to column 3, the first column is the total effect, while the second column is where the outcome variable is the dummy variable, indicating whether or not a person ever have visited, ever has a dental care visit. And the third part is, well, essentially the intensive margin, which measures a log linear regression on those who ever had a dental visit. Any question from there?
Can you remind us what the mean number of visits are? Visits, yeah, so we can think about this in terms of percentage terms. Is that a small number or is that a big number?
The mean of what, which number?
Visits, yeah.
Okay, I will have a quick check. Okay, so let's first go with the mean of the total dental visit is 0.81. Okay. 0.81. Because really we see that, so about just 1/3 of the population ever had a dental visit, and so that's really a lot of zero out there. So if we average out,
How many of them actually saw, I mean, there's like, how many people who never had a visit, because of this? I don't know.
because of,
There's a big graphic dimension here that is exciting. Part of the scope thing is that you get service scenarios you never had before.
yeah,
That's column 2, right? Column 2,
yeah.
5, 8.
So yeah, that
Can you explain that how that works? Then?
the coefficients in particular, or
Just explain. Yeah.
okay, yeah. So
Start explaining.
Yeah, so maybe I can go back to the difference in different setting. So the setting of a difference that, because we really want to have a treatment group where they have experience change, but there could also be some other trend. So we really want to difference out this part of the natural trend. So and so
He wants
so
you to
essentially,
interpret. He wants you to interpret that coefficient in words.
okay.
All right, so you can go back to that table.
Yes, so again, these are the, the estimates of the policy effect, I can say. And so if we look at column 1 of panel A, it essentially means expanding the scope of practice, or say the autonomy level for dental hygienists, increase the dental care visit by 0.02.
What does that mean?
That's percentage points?
Oh, no, it's that's a linear model, so it's in terms of visits.
Is that 0.02 visits?
Yes.
So it's
Yeah.
tiny, it's tiny.
No, it's not tiny because she just said that the mean level
The mean is
is
0.08.
0.08.
Yeah.
So this is a
point-
0.025 increase on a 0.08 base.
Yeah, point.
So it's a big effect.
It's outrageously big.
Yeah.
Oh, 0.8.
0.8. Oh, sorry, I misunderstood. So it's not very large, but it's there.
Yeah.
But it's not there actually because it's not significant.
So here's the thing, because what we find here is that if we look at the extensive margin, there isn't much difference out there, because if we look at column 2 or like column 5, column 8, there's no significant results out there. So basically what we find here is mostly focused on the intensive margin. So essentially those who have ever visited a dental provider tend to increase their dental visit when there is expansion in the dental hygienist autonomy. Yeah. Okay. So, okay. Oh, sure. So here we do not, this is the part that do not necessarily deal with the dental hygienists, but in general, we do see that dental hygienists tend to, are more likely to provide services on preventive care visits. And that's why we really want to focus on preventive care visits. But when we categorize preventive care visits, depends on what a type of services that has been received during the visits. And so preventive care, we include tasks like sealant or examination, x-rays. So those are the things that we consider preventive care. And treatment care is rather root canal or tooth removing, tests like that.
I mean, is there anything up there that tells me how big an increase is as we go from 1 to 4? If we go from the worst to the best?
Yeah, so here, I think it's more like an increase in general, so.
No, I want to know what that number is. I mean,
They're all zeros. None of them are significant.
Yes.
She's not finding significant effects on anything.
okay.
Yeah, that's the thing. So,
How can you see 1 to 4? Right? Where's 1 to 4?
1 to 4 is in panel A.
It's what?
It's
I just
in,
want to see the number.
of the effect.
If I go from the worst case to the best case.
Yeah, we can test on that, yeah.
Okay.
I don't have that right now. I'm sorry. Okay, any other question? Okay, so we also look at dental care expenditure, but again, we probably want to ignore the first column for each variable, because really it's a linear model. We will want to replace it with the total marginal effect from the two-part model later, because really it is the distribution of dental care, of the expenditure is wide. So so again, the results quite similar to the previous one, and we also, the significant effect is only seen at the intensive margin in panel C. And we believe those increase in expenditure is almost exclusively for third-party payment, because we also find in panel C of column 6, the coefficient is similar in magnitude. Okay, so here is a robustness check. As I said, here we remove state-specific linear trends to see if we are really over-controlling in our model. But the results are still quite similar, except that we start to see a significant effect in the total effect for the total visits, which is again in the change from level 2 to level 3. And also, if we look at preventive care visits, and there is also, we also start to see significant effect in the intensive margin if we look at column 6. But still, we want to be conservative in our analysis, and we still want to focus on the models with state-specific linear trends. But still, because we do see some effects out there for the preventive care, so we further break down to different services that are received at each visit. So we focus on examinations, cleanings, X-rays. So those are the type of services that dental hygienists are allowed to perform in some states. And we also look at the fluoride treatment, sealants, and filling. So if we look at examinations, results only shown at the intensive margin, but when it goes to cleanings, we do see that in panel C, we have significant effects in both intensive margin and extensive margin, and also total effect as well. So if we look at X-rays, and still, we also find some significance in the total effect in panel C. So I think overall, we do see that there increasing in the dental hygiene autonomy level does increase the utilization of the preventive care when we look at each specific services, and in particular, they are examinations or cleanings. And also like fluoride treatment, and also there is a little bit out there if we look at panel A. So when it comes to sealant, I think we mentioned that at some point. I think we don't find much results out there, probably because the proportion of sealant visits is quite low in our sample. If we look at the sample size in column 15. So just 10% of the population ever received treatment of sealant. But the interesting result comes from the fillings. So actually, filling is considered dental treatment, not preventive care in our study. And we do see that there is actually a reduction in the filling service. So I think if we consider, the reduction in treatment is a consequence of well, people receiving more preventive care, and it could be an evidence probably to support the efficiency delivery of dental care. And we also look at health provider shortage areas. So most likely to be rural areas or poor areas, and that's also what those laws aim at. And really, we do see that in fact, there are more significant results out there, and if we look at the magnitude, and it's even larger than the full sample. And also, we start to see some effects even in the preventive care at the intensive margin. Another thing we have done is, as I said, for each visit, we are able to identify what type of providers are seen during the visit. So we further categorize into visits to general dentist, and also visits to only dental hygienist, and visits to both. So we are trying to find if there is any labor substitution out there, but turns out our results, if you see, there's not much like significant results out there, so we do not have evidence to support the labor substitution between general dentist and dental hygienist. Okay, so that's what I have today. So our finding is that in general, when the autonomy level is increased for dental hygienists, there tend to be increase in preventive care visits, especially for the specific tests like X-rays or cleanings. And also, we also see large increases in the health professional shortage areas. So we still believe that expanding the scope of practice for dental hygienists tend to improve the efficiency in the delivery of dental